Welcome, everybody, to our Action Awards Cycle 2 Final Report presentations. I am Gina Schoen, Manager with the Hartford Change Agents Initiative. Today we will hear the final reports of 5 of the 9 Action Award projects that received funding for the period of January 1st, 2015 through December 31st, 2015. The other 4 projects will present on Tuesday, May 3rd, so if you haven't already, we invite you to register for that webinar also. I just want to give a little bit about the Change Agents Initiative. The John A. Hartford Foundation Change Agents Initiative accelerates sustained practice change that improves the health of older Americans, their families, and communities. It does this by harnessing the collective strengths, resources, and expertise of the John A. Hartford Foundation's interprofessional community of more than 1,500 scholars, clinicians, and health system leaders. The Action Awards are one-year grants of up to $10,000 available to interprofessional teams led by alumni of the John A. Hartford Foundation. The purpose of these grants is to achieve meaningful change to practice or policy by the end of the one-year grant period that will improve the health and well-being of older adults and or their families. Since August of 2014, the John A. Hartford Foundation has awarded 34 Action Awards through 4 cycles of funding. Action Award projects represent a range of evidence-based practice and policy change ideas implemented within various settings, including hospitals, skilled nursing facilities, and the community. As you listen to today's presentations, we encourage you to note projects or components of projects that could potentially be expanded into your organization. You can then follow up directly with the project leader for more information, or you can contact the change agents. You can contact us at changeagents365@giron.org, and we can send you the contact information. So before we get started, we wanted to review how the presentations will work. Each team will have up to 6 minutes to present. This will be followed by up to 14 minutes of question and answers with our panel and questions from the audience. Please note, audience, that you're in listen-only mode. Should you wish to ask a question of a project team, please use the chat feature located in the lower left-hand corner of your screen. We will be collecting questions throughout each presentation and try to address as many as we can during the allotted time for that presentation. To help us stay on time, we will use an audio cue to alert presenters when there is 1 minute remaining and a stop sign when time is up. And during the Q&A, we will show a slide when there's 5 minutes remaining. And please note that this webinar is being recorded and will be available on the Change Agents website, which is changeagents365.org, later this week. So now let's meet our panel. First panelist is Dr. Nancy Hodgson. Dr. Hodgson is an associate professor in the Department of Acute and Chronic Care at Johns Hopkins School of Nursing and associate director of implementation science at the Hopkins Center for Innovative Care and Aging. She is committed to exploring how to incorporate evidence-based findings into geriatric nursing practice in meaningful ways. Her program of research emphasizes the examination of factors associated with health-related quality of life in chronically ill older adults and the enhancement of science-based nursing practice in older adults at the end of life. Dr. Hodgson has developed a program of research focused on palliative care in older adults with complex healthcare needs. Her studies include an NIH-funded Career Development Award investigating the efficacy of sensory-based interventions designed to ease neuroendocrine distress, and an American Cancer Society-funded study comparing the effectiveness of palliative interventions in nursing home residents with cancer. Thank you for joining us, Dr. Hodgson. Our next panelist is Mr. Brian Lindberg. Mr. Lindberg serves as the Public Policy Advisor for the Gerontological Society of America. He also provides public policy consultation for a number of other organizations, including the National Association for Geriatric Education, the Women's Institute for Secure Retirement, and the Elder Justice Coalition. Mr. Lindberg has served as the Executive Director of the Consumer Coalition for Quality Healthcare since 1993. The Coalition is a national nonprofit membership organization composed of a diverse group of healthcare and consumer organizations representing more than 30 million Americans. Mr. Lindberg served on the planning committee for the National Quality Forum, appointed by Vice President Gore. He has also served on its board of directors and is chair of its Consumer Council. Currently, Mr. Lindberg serves on the Board of Visitors of the College of Health Professions, Social Work at Temple University. Welcome, Mr. Lindberg. And I would like to now introduce our moderator of the panel, Dr. Laura Gitlin. Dr. Gitlin is a professor in the schools of nursing and medicine and the director of the Center for Innovative Care and Aging at the Johns Hopkins School of Nursing. Dr. Gitlin is an applied research sociologist who is nationally and internationally recognized in the areas of non-pharmacologic approaches in dementia care, family caregiving, functional disability, and aging in place. She is a well-funded researcher, having received continuous research and training grants from both federal agencies and private foundations. A theme throughout her research is applying a social ecological perspective and person-directed approach, as well as collaborating with community organizations and health professionals to maximize the relevance and impact of intervention strategies. Dr. Gitlin is also involved in translating and implementing her team's proven interventions for delivery in different practice settings globally and in the United States. So welcome all of our panelists, and thank you again for being here. So we are now ready to begin with our first presentation.
Okay. So our next team that will be presenting is led by Dr. Evelyn Duffy of Case Western Reserve, and we'll turn it over to you, Dr. Duffy.
Well, thank you very much. I think that we all have learned from our experience that the most important part of these projects is picking a great partner, and I just think Jennings Center was the perfect partner for this, and I really want to thank Colleen Lavelle, who was the boots on the ground there in implementing this project. Our project had initially 3 focuses. First of all, we were looking at ways to keep it family-centered and patient-centered. And at the time that we made this proposal, there was a opportunity for the Jennings Center for Older Adults to be a beta test for a chronic disease management software that was going to integrate with their electronic medical record. And the idea was that would give the nursing staff an opportunity to see clinical guidelines and the highest level of intervention for different chronic diseases. Our concern was that those would be implemented and imposed on patients rather than involving patients and their families in the discussion. So that was part of how this began. We also had the concept of expanding the team beyond the usual traditional providers to include non-traditional providers such as housekeeping and dietary and the maintenance crew. And you'll see on other slides how that went, how that project was implemented. And then finally, we were looking for outcomes, and you'll also see that on the future slides. So if you can go ahead and move on to the next slide. It was designed to transform this chronic disease management. Unfortunately, the IT piece never came about. The expediency of implementing the chronic disease management software with their EMR was just not feasible, and eventually the kinks were just not going to be worked out, and that piece of it never happened. But we did have great success at creating what was called Team Aware, and we gave a contest to the participants on this floor in the skilled nursing facility at Jennings Center for Older Adults to pick their own name, and this was the winner, that they became Team Aware. And then we had these other goals of decreasing the hospital readmission rate to no more than 10%. I think we're all aware of the importance of not having patients go back to the hospitals, and hospital systems are choosing their skilled nursing facilities based on their readmission rates. So it's really a crucial component going forward of doing excellent care so that those patients don't have the problem with transitions of care and end up back in the hospital. Another goal was a 90% return to community rate. These are skilled nursing patients, not long-term care patients. So the goal is that they will become
well enough and back to baseline enough that they can go back to their home or their community setting if they live in an assisted living, for example. And then finally, we were hoping to see a 90% patient satisfaction with this project by Team Aware. So if you go on to the next slide, we had a lot of stakeholders in this project. It was going to be time consuming and take away some care time from the staff, and so we really needed the support of the Chief Operating Officer and the administrator. Also the Director of Nursing, who was huge in buying into this project and supporting us throughout. And then, of course, the team members themselves, the head nurse on that skilled nursing facility, and the nurses and care partners and housekeepers and all of the staff that were involved, and also having buy-in from the patients and their families regarding the decision making. We have this value proposition, which you can see here, that we would achieve the quality outcomes for successful hospital partnerships, prevent hospital readmission, and we would rely almost exclusively on nurses for patient monitoring and reporting. That unlike models that rely on that, we would have this broader team that included these non-traditional elements. And go on to the next slide. So we had for our data, de-identified patient readmission and return to community data. We did an anonymous patient satisfaction survey, and we also surveyed the participants in Team Aware to see what their feedback was about it. There was a lot of skepticism by many people that the housekeeping and maintenance and dietary would buy into this idea of being more of a participant in the care of the patients. And one of the ways that communication occurred was in daily huddles. There was a lot of concern that those daily huddles wouldn't be very effective or that people would not attend them. And it did get off to a bit of a rough start, but by the end of the project we saw a lot more participation. One huge transition was having it not become nurse-led and really letting the other participants on the Team Aware be the partners in that daily huddle. So the staff evaluation that we did was gave us really excellent feedback regarding their participation, and they scaled on a Likert scale. They were at the high end of the scale in giving us feedback about their appreciation of the project, and there were really no specific negative comments that we received, and a lot of positive support. Other more concrete data that we received, the average 30-day hospital readmission rate, which we had as a goal of 10%. As you can see here, there really wasn't any significant change from the year before the project was initiated until the year after the project, or the year of the project initiation. But we had, just the year by, it was probably at least April before we really had the team up and running, and there were still kinks that worked out. So I really think that data will be more telling to collect it again in 2016, in this year, now that the team has been up and running for a year and has had an opportunity to smooth out some of the wrinkles. The other thing was the 90% return to community rate. We did have an increase, which I thought was fairly significant, that you can see here, from 59% to 75%, but we're still working toward that goal of 90% return to community rate. And then the patient satisfaction, as you can see, we met that goal. If you can move on to the next slide.
We're just about a minute left.
Okay. So how many people we impacted? You can see that there was a significant number of people impacted. 878 older adults and their family members were involved in the project, 34 healthcare professionals, and we had 39 staff members at the project site. So 951 were, oh, I'm sorry, these are your statistics. These aren't ours. I thought that was a little high. Go on and move to the next slide. So these were the benefits perceived, that the older adults got to participate in their care. The families were included in the discussions, and the staff and patient satisfaction was very high. If you move on to the next slide, the lessons learned that staff can be successfully engaged in patient care teams. The original project design with the technology didn't work out, but we still were able to make a worthwhile project that really expanded the concept of patient care and team. And if you go on to the next slide, just in summary, the next steps, we plan to continue and expand the project. We've gotten support from Jennings management to do that, and they want to expand it to other floors within their own facility, and then to expand it. I would like to take it to other partners, other nursing homes and skilled nursing facilities, and work on expanding this then. And finally, we did have a product for dissemination. We had a communication board with images to inform the staff and the non-traditional staff about the patient care needs. And we have a really nice educational program that was able to give some basic information about chronic disease to that ancillary staff, so they would have more information about what to watch for in the patients that were involved with the project. Thank you.
Thank you so much. We're going to turn over to our panel.
So Brian, we'll start with you first.
Okay, thank you. Well, this is a great project, very exciting, cool that you've got already the buy-in from the organization and potential for expansion. One thing that occurred to me as I was looking at the folks you've got involved here in the team, were the teams aware of the role that often the long-term care ombudsman may play for residents that can't speak for themselves?
I don't know the answer to that. I don't know the answer to that. That point hadn't come up, and I don't know. I'm sorry to say.
No problem. And do you know, was there a patient or family counsel at this facility?
There is, but I don't think there is in the skilled nursing. The skilled nursing floor, the patient, the short length of stay in that floor, I don't believe that group participates in it. In their long-term care facility, there is. And I don't think that Colleen is on the speaker part of the call. She would be better able than I am to answer that question, but maybe she could, if she's on the call to chat with presenter, she could answer that in that comment section.
Okay, fine, thanks. And was there when you evaluated the huddles, is there a way beyond just participation that you evaluated the qualitative nature of the huddle itself? How if someone was going to do this in another facility, you might want to give them a sense of how to make those huddles work.
That's a very good point, and we do plan to do some follow-up qualitative interviewing now that the project has come to the end of the change agent piece, but we really are ongoing working with that. But what I will say is one thing we definitely learned in the process that it first became like the nurse reporting out. So it was just like the typical nurse report, and that was a piece that really had to be addressed, and because the idea was that we wanted everyone to participate, and so one of the shifts was to wait, not to have the nurse say anything, and encourage the other participants, the other team members to give their point of view. And we had to give them some questions to ask about that because they had never been thinking in that mode before. So we asked about, getting them out of bed, and were they cheerful, or were they having questions that morning, or were they struggling to get out of bed, or did they seem more confused? And so coming up with that list was very helpful in getting more involvement from the other team members, even the nursing assistants, which you would typically expect to be more of a participant. But I think it had, historically just been, well, first of all, there weren't huddles, and when there was communication, it was more top-down.
Yeah. Well, let me just because that tied to another question I have, let me quickly just say in your value proposition, you talk about, catching symptoms early that might prevent hospital readmission, and I just thought of the others. Were there other things that were benefits, such as the quality of life for the resident within their, within the facility beyond just not going into a hospital that you identified regularly or could measure in the future?
Well, I think that, one of the ways this thing started was looking at that chronic disease management software, that it's so easy to say, well, you're supposed to be on a no-salt diet, or that, you can only drink 200 cc's of fluid today or whatever. And that was something that we wanted to have the patient have a conversation about with the provider, because and that piece was the nurse practitioner would meet with the families to talk about those clinical guidelines, for example, and getting feedback from the patient. So even if maybe they were initially resistant, they might agree. And then there's always the possibility that they would absolutely say, look, I know what the consequences are, or their families would say, I know what the consequences are, but that's what we would like to do. So then you have to think about other methods to achieve your clinical goals and still have the patient be really participating in decision making. So I don't know if that totally answered your question, but I think that that was a big piece of it, was helping the patient to understand their disease, helping the staff, and even those staff that aren't really medically oriented, like the housekeepers, understand the disease, so everyone could be more on board about the ultimate goal of having the person return to their community setting.
Great. Thank you. I think it's important to talk about those quality of life issues beyond the readmission and some of the other measures. Thank you. Nancy?
Yes, thank you. It's a great project, and it's great to hear about the Jenny Center being such a wonderful project partner. It sounds like a wonderful organization. And reflecting on that, I was thinking about some of the generalizable lessons that we could learn from this. Given that Jenny Center is such a great partner and perhaps is special in that regard, what could other long-term care centers, skilled nursing centers really, learn from this? Because what I was hearing when you were talking really reminded me a lot of the lessons we've learned from the culture change literature. And one thing I'd like to say is I think that the lessons you learned in the IT not working out, and that piece of your project not working out, is still worthy of publication. There's lots of lessons I'm sure you learned in that really could contribute to other organizations who are also trying to embrace technology and finding it difficult to do. It's not a unique story, but I think it's worth getting out there. But to pick up on this idea of generalizable lessons, could you talk a little bit about the leadership structure? You mentioned the director of nursing being really wonderful. What aspects of the leadership structure at Jenny contributed to your success?
Well, I think
talk a little bit, like to say, about the culture of leadership there.
Well, it's very team oriented. Their own leadership. I have an opportunity to meet with them on a planning piece on a monthly basis, and it's a very cooperative group. So that's really helpful. Also, they're very forward thinking. The Jennings Center has embraced, well, even the fact that they were going to be the beta test site for that chronic disease management software, I think, gives you an example of how they're not one of the, they're an early adopter of change, not necessarily a late one to sit and wait to see if it works out before they embrace it. Their CEO is someone who came up through Jennings Center. She actually had worked as a nursing assistant there, and then went on to have other leadership positions and got her MPA, and now she's the CEO of Jennings Center. It's a faith-based organization, and that's a huge aspect of it. But the spirit of being interested in trying new things for the sake of their patients. It was already part of their mission to be patient-centered, so that was a no-brainer. Probably the most resistant person, honestly, on the team initially was the head nurse. She had been in her job only a couple of years, I think, or maybe 18 months, and had come on as head nurse after someone who everybody was not happy with had left the organization. So it took her a while to get a cohesion on the floor, and she was the most concerned, I think, that this would be a disruptor. But the director of nursing was so enthusiastic and really sort of carried her along in the process, I think. And by the end, she was as enthusiastic about the project as anyone. But that was, and then the COO was very supportive, and in fact, they've been fine about not only continuing it there on the skilled nursing floor, but also expanding it now to their other long-term care floors that they have in the facility. I do think that it is definitely something that could be implemented in other places, and possibly the statistics are what will be able to sell that, because I think right now everyone is under a crunch for reimbursement and finding that perfect mix of patients so they can have sustainability. So, even though those other pieces are very important, the reality is if you're going to sell it to administrative people, for a lot of it, they're only going to be looking at that portion.
Great point, I think. Although, as I was just thinking back about some of the culture change literature, some of the issues you raised about having supportive leadership, having a forward-thinking, as you mentioned, early adopter kind of an organization, that kind of culture, very mission-driven, and then having that head nurse sort of as your local champion are all the key ingredients that have been discussed in literature about adopting culture change. So I think there's some great lessons here for other skilled nursing facilities thinking about adopting this kind of a team-based rounding or huddling, as you mentioned. I wanted to my second.
Just real quick, the one thing I omitted, and I'm really, that was a terrible oversight on my part, is really Colleen Lavelle. If it hadn't been for Colleen, I'm not sure any of that would have happened because of her personal relationships with all of those people. I was very lucky to have her as a co-project manager.
Great. Well, that's wonderful to hear. I wanted to get back to Brian's point about adding quality of life as part of your value proposition, because in your original application you talked about patient-centered care. It's a term obviously we toss around a lot, and your huddles were kind of a way of operationalizing, I guess, this idea of a patient-centered care conference rather than going back to the old nurse report as the traditional method. Were there core elements of the huddling that, like, if we were to think about how to operationalize patient-centered care, what are the core ingredients of that when you're thinking about rounding? What were some of the core elements, or how would you say it really was patient-centered?
Well, another aspect was the fact that the patient and their family were involved in the decision-making process. So regarding all of their care plan, that it wasn't just this is your care plan, love it or leave it, that they had a chance to give feedback. And then the fact that what the team was bringing to those huddles was that particular patient's mood, issues, concerns that day that may not have gotten communicated if you're just going in, passing your meds, just getting them to eat their meals and counting calories, but really looking at that individual. And so those discussions weren't about the disease process as much as they were about the individual patients and issues that the families may have raised. So I think that I think we were successful in that regard.
So, were the families were there during some of the huddle meetings, or
the families and patients they could be included. The families weren't there necessarily. The timing of the huddle really changed the components of who was there. The patients, I don't think the patients were ever involved, but families could have been involved. But they do have patient conferences with the patient and their families on a regular basis. So those messages could be transferred to the team through the huddle.
So hi, this is Laura, and I see the time is up, Simon.
Okay.
There's so much richness here to discuss. I'm just going to have one concluding statement, and just based on what Brian and Nancy were saying, what I think is so critical, and you may want to tweak your value proposition, is that you were able to equalize roles and change from a hierarchical to a true team approach. And I think that's very important because you're not adding staff. It's not that there's extra time and, extra expense, that you're not adding another team member. You're expanding, using staff who are there. And then the only other thing I wanted to pick up on, and then we'll move on, is some of what Nancy was getting at, and that is you've learned so many incredibly important elements of how to start the team and change the dynamics of a hierarchical structure. And I'm just wondering, and we won't have time for you to answer, so I'm just going to pose this as a question, whether you have lessons that you could think about in terms of how to sustain this team. So, starting is one thing, and you've been very successful. What does it take culturally, structurally, possibly financially to keep this going in a setting? And with that, I just want to congratulate you again, and we will move on. And our next team presentation is a project led by Dr. Stephanie Bruce of Washington Hospital Center and Georgetown University School of Medicine. And so, Dr. Bruce, hand it over to you.
Thank you so much. The project title was Assessing and Addressing Caregiver Needs in the Caregivers of Homebound Elders. The project team was really, Ruth's name is second here, but she was the leader and the master of most of the work on this team, and we were assisted by our social work and administrative interns. Next slide. But it was really actually the whole house call team, and just to give you a picture of who we are and where we practice, some of you know our team. It's based out of MedStar Washington Hospital Center, and we serve as primary care physicians, and we bring social work and home services to about 600 homebound elders and their caregivers. And as a note, because this is part of our value proposition, we are also participating in a Medicare demonstration project called Independence at Home, which I've abbreviated IAH throughout this talk, and we're members of a consortium that includes sites in Pennsylvania and Virginia. So this project was designed to develop and implement a plan to really, in a more systematic way than we had in the past, address caregiver stress because of its impact on our patients in addition to caregivers themselves. And our goals were to educate the staff and reach out to caregivers to address their stresses and burdens. Next slide. With the goal ultimately to disseminate within the Independence at Home group. Our goals and objectives were to reduce caregiver stress, to improve the readiness of our clinicians, not just social workers, to address and mitigate caregiver stress, and ultimately develop a plan to disseminate, next slide, our ideas across the Independence at Home consortium. So our main stakeholders obviously are patients and families, our own clinicians as well, but our payers who are Medicare and also DC through the Medicaid waiver, which funds a lot of care for these patients. So to that end, our value proposition, as I phrased it, was that addressing caregiver burden can reduce burnout in caregivers that ultimately can lead to high-cost events like unplanned hospitalizations and long-term care placement. Next slide. We approached this measuring results with a survey both to our patients and families and then to our staff to assess their readiness. Next slide. Actually, next slide, because I'll discuss this with the graph. And this is the tool that we use to assess the caregivers. There was some discussion in our team about which tool to use, and we can answer that in questions if people have questions. But ultimately, this was a tool that our caregivers could self-administer during a primary care visit, because it was actually our nurse practitioners and doctors that were doing this survey in the setting of a routine visit. Next slide. And this is our initial results on the level of stress in our caregivers. I'll talk about this in the comments, but one of the things you can see quite easily if you look across the horizontal axis, that's the scale of stress on a scale of 0 to 16. And although the caregiver burdens are obviously present and high in our practice, it was a lower percentage that actually fell into that high stress, high risk category. And the other thing we found through the survey is the sort of surprising number of patients who didn't have a formally identified caregiver, which I can talk about again. Next slide. We also surveyed our staff about their readiness to address, because we were going to go looking for problems, and we wanted to know if our staff felt ready before their teaching to kind of address the problems that we uncovered. Next slide. Next slide. These were our interventions: education to staff, caregiver conferences, telephone support to families, and these are the number of patients that we impacted. That's okay. Next slide. Thank you. And these were some of the perceived benefits. So the families, which Ruth is going to talk about in a second, felt supported by the program. We were able to tell our funders like CMS and show in some of our cost savings that we had fewer high-cost events throughout the year. And the staff appreciated their growing expertise. Next slide. We can just pass this. We had high ratings for our caregiver conference. These were some of the lessons learned. I personally was surprised by the large number of patients who didn't have a formally identified caregiver, and it really spoke to how many people are dependent upon sort of paid caregivers and the village of care. We were definitely set back by the fact that we lost half of our social work staff. They went on to bigger and better things. It just happened to coincide with the time we were trying to implement this. And Ruth sort of stepped into the breach, but she was also kind of had increased clinical care responsibilities during this time. But it was a great way to build relationships, and we have some new bonds with our clergy and with the Caregiver Action Network. And I was amazed actually in learning how supported some caregivers already felt before the intervention. Next slide. These are our plans to continue. We still are working on developing potentially a toolkit to disseminate with our IAH partners. We just 2 weeks ago have started a new site in Baltimore and want to disseminate there, and ultimately with a plan to disseminate to our other IAH sites. Next slide. Next slide. I just want to leave you with some comments. Ruth, if you want to come off mute. I wanted, next slide, to just share with you some thoughts from our patient.
Right. Our caregivers have expressed meeting other caregivers, either at the conference or the monthly group, and they've reported 4 things. One, reduced isolation, that it means a lot just to be able to communicate with people in similar situations. 2 of our caregivers joined a water aerobics class together. Second, they got a new perspective. They liked trying different ideas. They said it helped them grow, particularly with self-care. Someone said, I realize it's okay to take care of myself. They also liked learning different tips to try. They found that very helpful. Third, members of our caregiver support group felt humor was really important. And one of them said, you can have more fun laughing about it than just sitting at home. And fourthly, they expressed that there was such a caring touch, that friendships have formed. And actually the woman whose picture you see recently died, and 3 fellow caregivers came and attended the funeral. This caregiver was very, very touched by that support.
And that is all. Thank you.
Excellent. Thank you so much. Nancy, we'll start with you.
Sure. I congratulations on such an ambitious project. There was just quite an undertaking to think about the many unmet needs of caregivers who are so hidden in the population, and how to begin to just help them with an approach that sounds like it's going to be sustainable and that you're going to be replicating it elsewhere, which is really exciting. And congratulations on the CMS funding as well. My question had to do with what were what are going to be, I guess, the toolkit ingredients, thinking about the sustainability of this. And Ruth pointed out a couple things. One was, I guess, around teaching caregivers about self-care, the second being these practical tips, the third being humor, and I guess another one was sort of this high-touch kind of concept. Are they really the key ingredients, or could you talk a little bit about what you think the key ingredients or what, that really address the largest number of unmet needs for these caregivers were?
Yeah, thank you. I love that you actually went right to the heart of what we are actually still struggling with, and I will let Ruth chime in if she wants to, but I won't put her on the spot. I will say our biggest learning over the year was trying to figure out a way. I mean, this was really our question when we started, and the deliverable that I wanted to deliver at the end of this year, which I would say we have not completed yet. And the reason is not because we haven't been working toward it, but simply that I think we are still asking the question. So I think the toolkit is not what I imagined, in that it's not just the tips and tricks like you talked about, although I think those are helpful. I think that the toolkit is much more conceptual, and it involves, one, doing the survey. I know this sounds silly and maybe even self-serving, but actually taking a moment to explicitly address the issue and open the door was hugely powerful in and of itself. I thought this was a throwaway activity in the sense that we needed to do it to get to the next thing, but opening that door was huge, and also put the clinicians, the non-social work clinicians, in the seat of doing that work. So again, that was another one of our goals, that all the IAH sites aren't going to have the luxury of the social workers that we have, and we want to kind of empower other clinicians to feel not scared to open that door. So I'm getting long-winded, but the toolkit is, one, doing the survey up front. Two,
that's great.
I think I learned that, although initially, and Ruth can correct me if I'm wrong, I think I was a little skeptical about a caregiver conference. It felt, forgive me, is that a little old school? Is it actually going to add burden to the family? But a place for the caregivers to physically come together, or virtually, these telephone calls that we do as well, but a place or a means for the caregivers to come together is piece number two. Being willing to do it after hours is important, because as I mentioned, a lot of times we go to the house, the caregiver isn't actually there. So doing it kind of on their time and simply recognizing their value is another piece. And then I think and then tips and tricks. So I think the simpler things are, yes, developing a short list of tips and tricks. But I think the two most valuable things, honestly, were asking the questions and providing a means for the caregivers to come together. Ruth, I don't know if you want to add anything.
Right. Yeah, I can't emphasize how important that caregiver conference. We pampered them with breakfast and lunch, giving them plenty of time to get together and talk. And over we heard, I thought I was the only one experiencing this, and I didn't know anyone else, was having, these kinds of concerns. So, yeah, I think that that is key. Also, in our caregiver support group, we worked with a book that really had monthly assignments of people examining their inner thoughts about caregiving, their frustrations and things. And for the group coming back, either in person, because we had an in-person group as well as people could call in, people found that very valuable, sharing that, and said they were able to hear things from others and read things that they were not allowed to really let themselves think about before then.
Thank you. What is the name of the book? Is that something you developed, or?
No, it is a book by Jane Hamilton, name of which I'll have to.
That's okay. That's
find
okay.
again.
I just if it's something you developed.
Yeah, she did a wonderful job. She actually spoke at our caregiver conference.
Great. Thank you. Okay, I'll let Brian pick up.
Thank you. This is. These are such wonderful projects. This one made me think that if there's one thing all of us who have been caregivers would agree upon, even whether we'd admit it or not publicly, is the element of stress. And so you've zeroed in on such an important area. let me start with kind of an odd notion, and that is, what does all of this cost to, if one is going to do this right, if you're going to have a toolkit out there and such, did you think at all about what this costs to spend this kind of time, both training and then doing what you need to do with the caregivers?
So our main out-of-pocket, our main out-of-pocket cost were the caregiver conferences. They were expensive to hire the speakers and people. That day was expensive. The rest, it's hard for me to put a finger on, not because Ruth's time isn't worth something, but she just kind of did a lot of this as part of her daily work. But this was funded with this grant, and in terms of thinking about the value proposition going forward, the pitch is if you have a payer who's paying you based on, quality and cost savings, you're definitely going to get the bang for your buck if it's costing, $10,000 to get this off the ground.
Well, let me jump then to something that I was thinking. Is there some sort of a broader policy goal? Did you think in terms of, boy, we've got something here that we could try to influence the whole, Older Americans Act caregiver support program? If there was more of this going on out there at the local level, that got me. That's part of why I was thinking of what would cost.
So my policy pitch was so I was thinking a little narrower, but we are a demo project for the Independence at Home, which ultimately Medicare is talking about making a full benefit with that number I put on the slides of potentially nationwide 10,000. That's their cap imagined right now, but one pitch is. So just to come back, I'm not sure if you need to dictate the toolkit, but that addressing social work needs, including caregiver stress, needs to be a component if you're going to participate as an IAH site. So that's my policy goal, and that is, I think, the pitch to Medicare.
Okay, and I would just suggest.
Can I jump in, Brian? Sorry to cut you off. We do have an audience questions. Can we go ahead and ask it?
Hi, Dr. Bruce. This is Angela Bowman, the Program Director for the Change Agents Initiative. And we've had a number of people who've noted that they found your presentation very fascinating, but they were wondering, that high population that identified as not having a caregiver, do you have any thoughts or thinking on what could be done with that population?
Yeah, so another thing that I think is a model is I have the luxury not just of having great people, but of working in D.C. where the Medicaid waiver program for elderly and disabled funds, it's a program that essentially is trying to keep people in the community. So that program participates by paying for aid services in the home up to 16, in theory up to 24 hours a day. So that group that, quote, doesn't have caregivers has paid caregivers. And it's really a program that exists as an alternative to putting people in long-term care. So that's how those people are able to be in their home. We have talked a little bit, we've barely cracked the door on, those people still, those caregivers, those paid caregivers, employees, if you will, still also have stresses. They were not in this program at all, and I think they need to be. But I don't know if it should or would be part of our program, or maybe needs to be part of the agencies that are providing those services. I'm not sure, but the short answer is I don't have an answer for those people. But what I have learned as part of this is those caregivers have their own stresses. They're just different from those of family caregivers. I don't know if that answers the question, if that's the people we're trying to get to.
No, I think that's a great answer, and I think it also really highlights this need to think beyond just the four walls of the the hospital or the system, and really look out into the community. So I think I think you've addressed the great need of both the stress of those family caregivers, but then also those who are paid caregivers for older adults. So thank you.
Okay, we have about a minute left. Do you have any final comments, Laura?
Yeah, well, just want to dovetail on this last question, Dr. Bruce, and it's a really great observation and outcome from your project in terms of the number of people who don't have caregivers but do have caregivers. I mean, family caregivers but do have, and I just want to say this is more from some small survey work we've done and experience with this direct service worker that many of their stressors are similar to families, because particularly for caring for people with dementia or cognitive impairments, they're not adequately trained how to manage the troublesome behavioral symptoms, for example, that occur particularly in providing direct care, bathing, dressing, and so forth. And then the other thing is that we ignore that, in fact, direct care workers do develop meaningful and profound connection to the people they're caring for, and we do expect them just to go forward without any recognition of their own need for grieving. And so I think there's very clear interventions that could be done with this group that overlap with families, but also, I agree, could be different. And then the only question I would have is, I love your focus. I love your focus, of course, overall, but I particularly looking at readiness of clinicians, and I was wondering if you could talk a little bit more how you define that, how you operationalize that, if you measured it in terms of readiness before your program versus after, and so forth.
Yes. So this was the readiness scale was kind of before we implemented, and we actually had planned a post-survey to see if they felt any more competent. We just have not done that survey. It was a very simple kind of 6-question survey, and I can share that with you if you want, but self-rating people whether they felt, sort of completely unprepared or not knowledgeable, a little bit knowledgeable, partially knowledgeable or fully expert in each of 5 or 6 subcategories of addressing caregiver stress. Like, do you know where to refer someone if you identify X, or do you know how to provide a brief count? So very specific questions about just their own perceptions of their expertise. That's what we were trying to get at.
Oh, that's great. Yeah, good. Just so that you're aware, we have been working in this readiness area in dementia and looking at both families and clinicians, and are trying to develop a scale, and I'd be happy to share some of those items.
I'd love it. Thank you so much.
Yeah, sure.
So our project was a hidden safety resource, family caregiver participation in MedRec, and we had a practice team and then an academic team. And I do believe that the real benefit to these projects is the expertise of these teams. And appreciation goes out to University Hospitals and Kathleen Vidal and Dr. Stephen Gravenstein, who were our co-partners in this, and then Jean Hitch, who's also on the call, who will be available for questions from the academic side. Next slide. We did put a little abstract in there that's not for you to read, but just for future use, if you get the slides. But our goal was to implement an educational intervention to engage patients and families in this MedRec process on 12 medical surgical units. 4 oncology units were initially put into the study, but we didn't actually get to them. The educational intervention was actually a bundle. It was a video that was going to be shown on the hospital TV educational system, and then participating of families and patients at the medication reconciliation at discharge. We also vetted the video that we did create with our patient and family council to get their feedback on it, and we did make a few iterations to improve the video to meet the needs of the families and the patients who we thought were our main stakeholders. Next slide. So we do, again, as all the other projects, have many stakeholders: nurses, patients, families, and then administration. Our value proposition we first created was for patients and families. As you see at the note at the bottom of this slide, we really got coached by the Johnny Hartford team during the session where it was face-to-face on the fact that really the patient and families were not our main stakeholders, that our real stakeholders were the nurses. And so then we created the current value proposition, which was that our medication reconciliation video helps nurses who want to decrease errors by having accurate medication lists and increases patient and family engagement in their care, unlike the current practice where the clinical team does the work and does not include the patient and family members in the medication reconciliation process. So this was a pilot. We first piloted the intervention or implementation of the bundle on 1 unit, and then we moved it to 3 units, and then to 8, and then to 12 units. We used the Institute for Healthcare Improvement Scalability Principle for this implementation strategy. The implementation was also augmented by audits. So we did feed data to each of the units as to how many video views their unit had had in the past month. We then let the units sort of self-create the implementation tailoring so that they could determine what strategies that they would use then to increase the number of video views on their unit. Units choose projects such as nurse residency projects. That was 1 unit strategy. Another unit used volunteers to help to increase video views. Another unit used students. And most of the units didn't just use nurse-driven strategies. Next slide, please. So our results were, we looked at process and outcome measures. Our process measures were the number of video views during the month. And we did demonstrate that about 500 patients out of the 6,700 that we measured, only about 6% had video views. Our outcome measure then was engagement of the family at the discharge med rec, and we did do 5,394 home phone call follow-ups. And we found that patients and families reported about 81% that they were involved in the medication reconciliation process at discharge. We also were looking at the outcome measurement of decreased medication discrepancies when home, and we did find that about 4% of the participants who were called had some medication discrepancies upon home, returning home, and about 5% did require clarification of their home medications. Next slide, please. So our impact on the end users were that we did reach about 7,500 patients and their family members and about 400 nurses or healthcare professionals through our orientations and through our orientation processes on each of the units. We also had 10 staff members in the project site who were involved for a total number of about almost 8,000 end users. Next slide, please. So the perceived benefits for our stakeholders, for older adults, really a reduction in errors during the transition was the biggest benefit for older adults, and clarity of their discharge medications. Also increased patient family satisfaction. Families also became more involved and engaged, and also the organization benefit was increased patient satisfaction, improved efficiency, costs. Next slide, please. Our lessons learned was that there really was no culture of video education in the hospital, and that we needed to have a value statement from all of our stakeholders. It also required hardwiring the intervention into the educational delivery process and accountability for the nurses that they needed to be engaged. We had to let each unit figure out what their next implementation strategy was, and some unexpected successes were that student teams on the units really helped the process. Next slide. Our next step is to expand to other units to test patient and family engagement strategies, and then also we did a culture change implementation to enhance appreciative inquiry on the units. Next slide. And we also presented the work. Our student team presented at this venue and then also at our local hospital, and we did create a dissemination toolkit that will be spread throughout the university hospital system. Also, we submitted an AHRQ grant for the 2017 Quality Safety Education for Nurses Conference that will highlight implementation strategies for nurses. And also, we will be submitting an R01 in February on testing the spread of this process, looking at audit and feedback compared to self-efficacy strategy for change. Oh, time is up, but there were a couple patient stories, and I just want to thank the Hartford change agents for this opportunity, and also the staff at the hospital and all of our patients. This was a great opportunity to impact the lives of older persons and their caregivers. Thank you.
Wonderful, thank you. Brian, we'll start with you.
Thank you. Well, this must have been quite a rewarding project to be working on, and I was impressed with your involvement of the families and patients early on in the process. Working with consumers, I know that doesn't always happen. I had two questions. The first was, I often think of discharge planners and often being social workers and such, and the role that they play in medication issues. And I just wondered, there wasn't a lot of mention of social workers or discharge planners. I know this was focused on nurses. How did that all work into your project?
I think that's a really excellent point, and that we didn't have a social worker partner on it, and we also didn't have pharmacy as a partner on this project, and those were definite limitations. And I do believe that we need to start looking at models of delivery where it isn't the responsibility possibly of one, discipline, and that it is a shared responsibility. Even with occupational therapy, that would also be another great opportunity to, go over medications and to reinforce this very important self-management skill.
Great. Well, you obviously have a lot of opportunity ahead to modify and share this with others. The other question I wanted to ask was really around how you're going to get beyond just sharing this with individual hospitals and at conferences. And I don't know if this is off the wall or not, but I was thinking in terms of the Joint Commission, hospital trade organizations talking about best practices. Are there any bigger players, if you will, that might somehow influence how this practice that you've developed could be done more nationally?
Yeah, another really great question, Mr. Lindberg. I appreciate that, and my view has always been sort of on the individual patient and not so heavy on the systems of care. But I think that, again, those are really good suggestions to look at other avenues for dissemination, particularly like maybe we were thinking pharmaceutical, like CVS and Walgreens, where they could tell, maybe give messaging to patients how important it is to really know your list of medications and always carry it with you so that you can be an active partner. We haven't gone to that step yet, but that is really, I think, an easy maybe next step to disseminate this important skill, even to a larger audience.
Thank you. Nancy?
Sure. Congratulations on a great project. I was thinking as you were talking about the parallels between this project and sort of the rollout of assistive devices, or even the MOLST paradigm, where you had this thing. In your case, it was the video, but it really was the process behind it and the conversations that had to happen as a result of the video that were the biggest player. And assistive devices, advanced directives. You have the advanced directive. And that's the thing, but it's really the conversation that is the important piece. And so I wanted to hear a little bit more about the process factors that you talked about in this dissemination toolkit. I mean, one, I guess, would have to be preparing the nurses that once individuals have these videos, they're going to be asking more questions, and so you're going to need to sort of prepare for some perhaps nurse resistance in that regard. And then you mentioned sort of this appreciative inquiry kind of culture. So then socializing nurses to a slightly different way of thinking about this as something that would empower them and help them in their work. So could you talk some about some of those process factors as lessons learned as you rolled out this video?
Sure. And then I know Jean Hitch is on the line also, so I'll say a couple things and then I'll give Jean a moment to respond. But I think that was our biggest barrier that we didn't anticipate. We just assumed that the nurses would take this on as another intervention that they would integrate into their normal work. But what we had found was that there was so much quality improvement fatigue that they were implementing like 10 or 12 new initiatives every month, and that they were sort of resistant, like, we can't do one more. We don't know if this is going to help, and, we're overloaded. And so that the process is the key to these implementation strategies in that you have to understand the barriers and facilitators and then identify strategies to overcome them. Jean, are you still on? She might have had a drop. So I think that was another one. And then we did find, so we had a student group who went into one of the units as a pilot for public health students in a quality improvement course here at Case Western, who did an intervention on a unit where they really did 4 PDSA cycles on that unit to get the increase in the video views. And what they found was that the nurses just felt underutilized and undervalued. And so then they were the ones who suggested this appreciative inquiry approach, and they did then get our business school in to do an intervention on the floor with the nursing staff to change that culture, to help the nurses to see that they are appreciated and they bring value to the patient encounters. And that did raise the video views on that unit by 50%.
Thank you.
I'm sorry, I still had my phone on mute as I was talking. This is Jean. One of the most important things we learned about the culture was that really surprised us was the variations among the cultures, and so much of it depended on the nurse managers. And we did start from the top down. We attended all the different meetings, and we attended many orientations. The successful units, I think, were successful in any kind of making, not specifically this project. I don't know if Mary mentioned we shortened the video to 3 minutes rather than 8, and we're in the process of seeing if that's making any difference, because we had many complaints from the nurses that the video itself was too long.
Good input.
Those are all my. We do have an audience question related to the video, so can we ask that right now?
Hi, Mary. A number of people are asking, is the video available for others to see, or do you just have it within your own system?
We could, share it with on the Change Agent platform and, create a link to view it. That would, we could do that. Mm-hmm.
That would be great. I think that the community would greatly appreciate it, as well as the people who are viewing the webinar today. So we can follow up with you after that, too, about posting the video on the online platform. So thank you.
Mm-hmm.
Okay, we have about 3 more minutes left. If panel, if you want to continue, or other questions.
This is Laura. I'll just jump in here, and then I'll see if Brian and Nancy have other things to add. Dr. Delansky, I wanted to ask you about 2 things, and one is the involvement of families, of course, is critical, and I'm wondering if you gave any thought or see a need to evaluate their readiness and ability to participate in medication reconciliation. So particularly when we're looking at family members who may be older or have their own health problems and disabilities, there's so many things that go into not only medication reconciliation, but the management of medications. And did you think about or take any opportunity to assess a caregiver's ability to participate in this whole process of medication reconciliation and management?
No, that is a really important component, I think, is readiness, readiness for them to even engage and change. And we did not. So that readiness survey, I think that Dr. Hodgson is maybe developing might even be beneficial. It may be specific to palliative care, but it could be maybe modified to be an important measurement tool for all of this patient and family engagement interventions. Yeah, that's a good point.
Yeah, great. And then a related point is there's so much involved with medication taking, and reconciliation is one piece of that. And I was wondering if in your experience with this, you would consider going beyond to actual management of medications at home. So, who gets it refilled, who picks it up from the pharmacy, who gives it, can the person and or the caregiver actually open any of the bottles? Do they understand how to set up a schedule? All of that. Do you give any consideration to that? Because reconciliation to me represents, as far as I understand the definition, one component of quite a complex set of tasks involved with medications and older adults.
Yes, I think That is an excellent point, and we really wanted to sieve it down to a very simple message. Bring your list, compare your list, and speak up. Like, that was the message we just wanted to convey. But Jean Hitch also is an educator and brought your exact point to the group and said, look, this is only a part of it. But we just wanted to keep it simple just to see if we could deliver just this simple message. So, Jean, did you want to add anything on that one?
Yeah, we absolutely considered all of those things, and as we went along, we had to keep it more and more simple, and we had to take out all the extraneous things to focus just on. We stop and pay attention, look at the list, and that was a huge message and change in people's thinking, because many of our Family Advisory Council and patients did not even think about the importance of taking the list or looking at it or even thinking about the medications at all. So I would say that if we could get this simple change to take effect, we certainly would add the complexity as we go along for all of those things. Absolutely thought about it. But as I said, we had to become simpler and simpler.
Yeah, and I agree with you. I mean, simplicity is at the heart of behavior change in a way, and in a way that's the beginning of this long process. And just from working with many families in dementia and just even experiences in general with older adults, it's often a surprise to families that they have to even consider medication. So I think you're absolutely right. Although I guess I would just say, as you already know, that that's only the beginning, because after reconciliation, it can all fall apart the minute they get home. So I'm glad you're thinking about that.
This is Nancy. I just wanted to pick up on that theme and go back to Brian's point too about maybe this has a real public health application. When people are in the hospital, they're getting so barraged with so much information, and the nurse also has to do a lot of education, and medication sometimes is just one small piece of that education. So maybe there's a bigger role, and I'm glad to hear that you're thinking about rolling this out into more of a public health arena, like the pharmacies, and the role of pharmacists who really want to be engaged and take a larger role in educating their clients for lots of business reasons and lots of engagement reasons. That maybe that's the direction this project could go.
That would be, this is Laura, that would be neat, because it could be a handoff, from discharge, this is what you focus, but then you do a handoff to the pharmacist or Walmart or whatever it is for the other pieces. That would be good. Great.
All right, so my project is on, it's called Relocation Amidst Revitalization, and what's happening in Detroit right now is that seniors are being relocated as the city redevelops. And so the project team, as well as other community partners, are very interested in the health and social sort of consequences of this involuntary relocation. Next slide, please. So the project was to track or interview 100 older adults who had experienced this. And to date, we've done 50. Oh, no, we haven't done 50. We're shooting for 50. We're probably at 41 or 42. So there was one building that 115 older adults were relocated from, and we wanted to get their experiences. But finding them after they've relocated has been harder than we thought. But basically, we wanted to be able to use these data to then go to policymakers and developers in the city to sort of talk about the experiences. Next slide. So, of course, everyone in the city is involved. So this project is really a result of 15 agencies in the city coming together. So we're on a coalition called Senior Housing Preservation Detroit. And so what's nice is the local area agency on aging is there, senior housing providers are there, and so we've been trying to use this project to then raise awareness on preserving existing senior housing, and then if people have to move, figure out ways to support them better than they were supported. So I think from the interviews from from my project, we can directly talk about where information gaps occurred and how seniors themselves what needs they said themselves. Next slide. So now we're at like 41, maybe 42. And so the other thing that's interesting about this is we had our interviews conducted in the new residences, so then we took observational field notes, and I trained the people doing the interviews in taking ethnographic field notes. So it's interesting, their assessments of the new living environments. And I think, next slide. So I will have to say that I think there's ways to, it was hard for me to come up with the number of 37, but I will say some direct result of our project is new developers who are thinking about converting senior buildings to market rate apartments have met with our advocacy group because they wanted to make sure that they were respecting and understanding the needs of seniors. So I would say our group counts that as direct result from our advocacy work and this project. So in a way, like residents of at least 2 other senior buildings did not have to move because of the work of this group. So we take that as a big success. Next slide, please. So let's see. So the older adults, I think there was a certain therapeutic aspect to telling their stories, and then also the older adults themselves are very excited that by telling their stories, maybe it would reduce the number of seniors who will actually be displaced. The organizations, we have built great working relationships around this issue. And then I think this, in a sense, will promote sort of a Detroit for all ages, which is something to keep in mind as the city transforms. Next slide. Oh, maybe next slide. So we presented a lot, and a lot. Sorry. Let's see. So it has been a challenge to actually locate seniors displaced, because if part of our questions are how do your social networks change or dissolve when you're displaced involuntarily, then obviously it's hard for us to find them. But we've been trying to use creative ways of both like word of mouth and then letters and then follow-up. We actually added to our IRB to ask people if they were in touch with other residents of their former building, and so we've then built on that information. Next slide. So I'll tell you that we are directly working with the mayor's office, specifically the Housing and Revitalization Office, on this project. We provided the city officials a tour of at-risk buildings. So they contacted our group, Senior Housing Preservation Detroit, to really make sure they understood what we were talking about. We've also created a documentary, which we're releasing next Thursday, where we're inviting city officials and other local policymakers to see the video as a way to discuss the issue. We're taking this video then to Older Michiganians Day in the next week. And while we don't have plans to expand in a concrete way, I think the movement, the group I'm working with, Senior Housing Preservation Detroit, has certainly established itself in the city, and I think developers know of us now, city officials know of us, and I think seniors themselves also have heard of our work. So I will end it at that, I think.
Great, thank you. This is Laura. I'm glad you were able to get on and discuss this very important project. And I'll ask Nancy, you to begin.
Okay, thank you. Your team has been incredibly productive. It is such a timely topic, and it brings such a unique perspective to involuntary relocation literature. Having worked in that literature for a little bit, we found that, and this is in senior housing in Philadelphia where people were moved out into the suburbs, we found, as with any move, it's incredibly stressful. But one interesting finding we had was that because the housing conditions were better where individuals were moved to, that they actually did better than those that remained behind. And I wondered if you had similar findings.
I would say that is true in some cases. It's interesting because I was just with my community partner, Kathy Karsten, the parish nurse, yesterday, and we discussed that. And so I said and also we're going to have a day this summer where we release our findings to the public and, invite the press and stuff. and city officials. But I think the way to understand it for our situation is that we have people can certainly talk about how the process was very, very difficult and stressful, and then I think of it in terms of there's some sort of resiliency that also occurred where people now have moved on and they see good in their new situations. But not everyone, because what I have found is people who relocated very close to where their other HUD housing building was actually face the chance that their current building is now going to be on the list to go market rate. So I've also encountered people with great anxiety. If you're 80 and just moved, are you going to have to move again in a year or two? So that is something, and there's this whole role of rumors in this process about because people are living with great uncertainty about the precariousness of their housing. I think when people have moved farther, maybe their physical housing is better, like in better shape at times, but they've really lost some social networks. So people say I haven't returned to my place of worship since I moved, things like that. So I guess I'm trying, we're still analyzing it, but trying to sort of not say that every move was bad, and in fact some people can point to things that are better about their move, but on the other hand, they can also, because the move was clearly not their choice, they would have preferred not to have moved.
Yes.
In all cases, even if they can see good in their new place, I think.
Thank you.
So
my
second question, yes.
Yeah. My second question really isn't about the relocation, the aspects of relocation in your study, but more about that you had this sort of unanticipated lesson around your ability to forge coalitions of multiple players. I think there's a real story in that, and a very generalizable story to lots of others who may be not interested in relocation per se, but interested in how do you form these coalitions around a compelling topic. So could you speak a little bit about that?
Yes, and also I have an article about that I'm happy to circulate on the establishment of this coalition and how we divided up committees. And it lays out the first year of the coalition. I'm happy to send it on to y'all. But I would say it's interesting because the coalition itself started because as a direct result of service providers at multiple agencies being called by seniors who didn't know what to do and where to seek resources. They were notified they had to move and didn't know what to do. And so it was interesting. Then the service providers came together and said, well, now we're all getting calls because people are very stressed out. And so then we realized, we have to first figure out even where these residents are going to go. And then one community partner actually did like a court injunction because construction had started in the building even though people were still living there, et cetera. So they were it started under very immediate pressing service needs. But then I think what was interesting is that we developed a capacity to say, well, okay, if we could input policy, what do we want to say? And then we realized if we did some research, which certainly thankful to the Hartford support for the project, then we would have some evidence to then go to city officials. And I think last December we went to the mayor's office and met with them, and now the city officials actually come to our meetings. So we meet monthly, and 2 members of the city are designated to come. And then so I think it's been an incredible process, which I'm flying in for the next Change Agents thing in D.C. to talk about, and I plan there to lay out the timeline of what our group has done. So now, we're planning commentary in the local paper about things. We're quite active, and I think it's also, as a developing researcher, helped me establish great ties in the city for other projects I'm trying to launch in the city. That this has been an excellent way for me to build partnerships that I think people can speak to my involvement in them. So it's been a very good experience. But also, I would say, very active, so it's challenging to balance with all the other responsibilities, but very active coalition.
Well, congratulations.
Oh, thanks.
Hi, this is
I
Brian.
think maybe if from a generalizable point of view, I have one article in Traumatology that outlines the establishment of the coalition. And I guess to be very specific, the coalition divided into 5 subgroups. So I am chair of the research subgroup. We have a communication subgroup, of which our two chairs are going to the Hartford communication thing in July. We have a relocation assessment subgroup and 2 others. So in a way, we divided the work and the specialties.
Hi, Tam. This is Brian, and thank you for agreeing to come to the Change Agents Institute, Policy Institute in June. I had a question on the advocacy tool that is one of your goals, the tool that is, you would share with people to help protect seniors and such. And it seemed to me like, I'm not sure, but are you going to also within that tool cover the issues around transition? Because those seem to be very different pieces. One an advocacy tool, and one a tool to help a city, agencies, et cetera, help seniors who are in transition.
Yeah, I do think there are 2 different maybe texts that are going to develop. So we have a relocation assessment tool. So if someone is relocating, this is what we've developed that we think will be helpful. And so we would probably want to package that with sort of tips on different stages of the transition as one tool. And the other tool is sort of a justification for why considering the role of senior housing in the city and the importance of sort of a Detroit for all ages is valuable to all community members. So I do think there are different tools. I would say we really focused in the last month and a half on the video, and it was interesting because the documentary maker was a person who just did a video on Flint, and so she had definite ways that she wanted to capture experiences of, and I'm happy to share the video as soon as we have our world premiere next Thursday, and it could easily be put on a link somewhere. But I think we've also been really focusing on the video because we feel like I think it's going to be 5 to 8 minutes video that we can play is the starting point, rather than even having people read things. So even thinking about textual medium, written words as, is that the best advocacy tool? So that we've kind of prioritized the video first because we want to see how much that will generate.
Great. And let me just say, I just to clarify, is there the potential for you to share this tool with advocacy groups in other cities that are facing similar challenges?
Yeah. And actually, Brian, we should talk about how I would do that, like what form would be useful and stuff. That would be really helpful because certainly our group is very dedicated, and we say in some of our writings that we want Detroit to try to, if we discover solutions or ways of proceeding in Detroit, we want to share it with other cities because this issue of gentrification and people being displaced due to it is clearly happening in many urban centers.
Thank you. Laura or anyone else?
Yes, thank you, Brian. This is Laura. So, Tam, I wanted to say that another area that I think your work is critically important to is the intersection of housing and health. Mm-hmm. And it's not just about relocation. It is about relocation, of course, but it is about, how the concept of the home and the house is essential to the health and well-being, particularly of older adults who become increasingly vulnerable to their living environments. And so I just want to put that out there as another area to consider in terms of where you could have an impact, and also draw upon theoretical frameworks and concepts to help frame what you're doing.
I appreciate that. So I've really very much been thinking of housing as a social determinant of health and how to think about that and how to consider moving in that process. Like if you have to move.
Right.
How to, and actually I'm developing sort of thinking about how people's circadian rhythms are changed when they relocate. So I'm actually trying to get into the circadian rhythm sleep research literature about that, which is a little different than, of course, this advocacy policy project, but in a way trying to really get, I think one of the reasons, one of the things that I've had difficulty is it's hard for me to tangibly say what the outcome of relocation is, right? I have qualitative work on it, but like in the process of 115 seniors moving, 7 of them died, and several of them developed sort of cognitive impairments at a much accelerated rate. But because we didn't measure it, we cannot link it to the process of moving. And so I've been trying to think of ways that are more tangible, that if someone is going through this process and we could follow them through the whole moving process, what are things we could measure of cortisol levels and things like that.
That's exactly, this is Nancy, actually. That's exactly what we did with our Philadelphia sample, is we looked at cortisol
yes. So I've been
levels.
also really thinking about how to do that work here.
Yeah.
Yeah,
and
that's great because these are forced relocations, so that adds another level of stress.
Right.
And the only thing I want to say, getting back to policy, and this is where I think you're going to the Policy Institute and then talking to Brian could be really helpful. I mean, the HUD has always been separate from, if you will, HHS, and so there's a lot of, how do we get them talking and cross-talking, et cetera, is really critical. And I think that with the affordable care, accountable care organizations, there is an increasing awareness of of housing needs and how housing intersects with aging. And here we have forced relocation. At any rate, I think that it may rise to a better ear, among policymakers. I have one very quick last question. What about water? And has the group
yes.
that you're working with been affected in any way by the water crisis in Detroit?
Yes. So,
that's a short answer.
Now I'm also exploring 2 city older person older person projects in both Flint and Detroit on water, because they both have very unique water issues, but older adults are affected in both. And so again, this link between housing and health and water now in both Flint and Detroit is very much on everyone's mind. So I would say, there's the relocation piece, which certainly is important, but there's also just sort of extreme concerns about clean water. So, my work is taking me in that direction also.
Yeah, by default you have
I am so sorry to have to jump in. We are at the hour. This is a fantastic conversation, and I just want to thank everybody who participated, our panelists, our presenters, the audience. This is really a lot of really important information to be shared, and we will post this. And I just want to remind you we'll be doing the other 4 on Tuesday, so if you haven't registered and are interested in listening in, please do register. And a final, I just want to let you know about another excellent opportunity that's coming up. The announcement for the Practice Change Leader program will be coming out soon, and so we strongly encourage you to consider applying for this. There'll be information posted on the Change Agents online platform and probably GSA Connect, and you're also welcome to email us for more information. So with that, thank you again for being on this call, everybody, and enjoy the rest of your afternoon.
Thank you.
Thank you. Thank you.
Thank you. Bye.